Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening. As always, go check out reallifepharmacology.com. We've got your free 31-page PDF on the top 200 drugs. Great study guide if you're taking pharmacology exams soon. Great refresher if you're out in clinical practice. Absolutely a no-brainer to go ahead and take advantage of that. Again, that's at reallifepharmacology.com. Free PDF on the top 200 drugs. Simply an email will get you access to that. All right, so we are talking medications in alcohol use disorder, and I'm going to focus primarily on three. Maybe I'll throw in another one or two here, but there's three big ones, and I would say two that are primarily used in practice, but one kind of maybe more of a teaching point. The first one I want to start with is Naltrexone. Now, this is actually an opioid receptor antagonist, so it blocks the effects of opioids. So you might think, what the heck are we using this for in alcohol use disorder? Well, it's actually been shown to reduce the rewarding effects of alcohol and also can help reduce cravings as well as binge drinking or heavy drinking episodes as well. Now, this comes in a couple different formulations. We do have oral that patients can take daily, so that is nice, but we also have an extended release injectable formulation too. So a couple different ways to make sure that patients have a couple different dosage forms and can get the medication with the way they want it. Now, I will say extended release injectable, typically much more expensive than the oral formulation in general. So that's an important thing to note there. But we do have a couple of different options there. Naltrexone, generally one of the first-line medications that's used in alcohol use disorder. It can be effective even if the patient continues to drink. So that's compared to like disulfiram, which I'll talk about. Patients can feel awful when they drink due to the way that medication works. So again, particularly useful to help with kind of that excessive drinking, binge drinking, heavy drinking days. From an adverse effect profile, generally kind of some nuisance adverse effects, nausea, headache, fatigue, dizziness. And of course, if you're, whenever you're giving generally a long-acting injectable medication like this formulation of naltrexone, you can have some injection site reactions, of course. Important monitoring parameters, liver function tests. So there is potentially some negative impacts there from an adverse effects standpoint. Pretty rare that this happens and does it on its own. But you got to recognize that you're dealing with a patient population that may already have some liver damage, liver issues. And so that's definitely going to be something to pay attention to. All right, so things to think about with this agent in general. Current opioid use. If you do an opioid drug screen, it's positive. If you know they're taking opioids, you're likely going to put them into opioid withdrawal. And in general, the patient is not going to be very happy with you. And so in that situation, it's generally best to avoid the use of naltrexone. The other situation is patients with kind of moderate or maybe even especially severe hepatitis, liver issues, liver damage, significant. We really need to weigh the risk versus benefits of naltrexone. And in patients with more severe cases of acute hepatitis, liver impairment, we're probably going to steer clear of naltrexone. And likely consider Acamprosate a more appropriate choice, which I'll talk about coming up here. So those are the two, I would say, biggest things with naltrexone, things that certainly come up on board exams as well. If you know a patient's on chronic opioids, if you start naltrexone, you're going to throw them into withdrawal. And if you know they've got pre-existing significant liver issues, they're having acute active hepatitis, naltrexone definitely not a good medication to utilize there. All right, next medication is Acamprosate. Mechanistically, this actually modulates glutamate and potentially has some effects on GABA neurotransmission as well. Dosing of this medication is 666 milligrams 3 times daily. So, as you could imagine, adherence may be a little bit more challenging with this medication. Also note, in patients with mild to moderate renal impairment, there may be some dose adjustments there that you need to do. So pay attention to renal function with Acamprosate. If it's too low, we may be avoiding this medication altogether. So it's helpful in maintaining abstinence. It's most effective when started after detoxification. The patient's been off alcohol for a little while. And then the most likely situation that you're going to see Acamprosate used first line is when patients have that significant liver disease where naltrexone is maybe a little bit iffy to use, or maybe we should avoid it altogether. Or potentially patients taking opioids, where giving naltrexone is going to put the patient in opioid withdrawal. Side effect profile of Acamprosate, diarrhea. That's the number one adverse effect to remember. Good patient education point, as well as something that's definitely going to show up on a board exam or a pharmacology exam. So remember diarrhea with Acamprosate. Other GI effects can happen, some nausea, insomnia has been reported as well, but yeah, that diarrhea effect is probably the most troublesome usually for patients in clinical practice. Monitoring parameters, so keep tabs on that renal function. If renal function declines, generally Acamprosate is going to be contraindicated when we get that creatinine clearance less than 30, and then dose adjustments for kind of moderate impairment, slightly above 30, we may need to do some dose adjustments there, so pay attention to that. As far as alcohol use, we're going to pay attention to, abstinence status. Are they, keeping off of alcohol? Are they not using? And then Acamprosate with the 3 times daily dosing, that's one you're going to want to keep tabs a little closer on monitoring adherence. Are they getting the medication refilled? And so on and so forth. If you're looking to pass your board exam or pharmacology exams, go check out meded101.com/store. We've helped thousands of pharmacists, pharmacy technicians, nurses prepare for and pass their board exams, and we can absolutely help you too. So all those links, BCPS, ambulatory care, geriatrics, nursing pharmacology, pharmacy technician review course, all those links can be found at meded101.com/store. All right, next medication I will discuss is disulfiram. This historically used to be used a little bit more when we didn't have some of the other options. I've seen it, I think, maybe once in the last 5 years or so that somebody's had it on board. Mechanistically, this inhibits aldehyde dehydrogenase, and by inhibiting this, you actually cause an accumulation of acetaldehyde after alcohol ingestion, and that can contribute to a disulfiram reaction, is what it's typically called. But what is that? You can have some flushing, some tachycardia, some GI upset, drop in blood pressure, and just patients feeling ill, patients feeling very, very sick. And so, as you can imagine, disulfiram is not to be used with patients still taking alcohol. It's basically used as a negative feedback type of situation. Now, in clinical practice, as you can imagine, patients who frequently stumble, trip up on using alcohol, they're going to realize pretty quickly that if they do this, they're probably going to want to stop taking their disulfiram if that becomes an issue frequently. And so Disulfiram, you tend to maybe get more of the patients not wanting to take the medication if they're concerned that they're going to slip up and drink alcohol. Okay, so that can definitely be a challenge to overcome. Now, if you got a patient that's super, super motivated and, they're not drinking alcohol, they're very adamant they're not, that type of thing, then maybe there's a small role there. But again, Naltrexone, Acamprosate, those are much more preferred agents. So again, this medication works primarily through behavioral deterrence in drinking alcohol. Again, you need highly motivated patients to use this, and definitely need supervision and adherence to the medication. Adverse effect profile. Patients can sometimes report some metallic taste with this medication, maybe a little bit of drowsiness, and then rarely some neuropathy and liver issues associated with disulfiram. All right, monitoring parameters, liver function tests, obviously adherence to the medication, and then alcohol avoidance, which is going to be super important for your patient counseling. Now, keep in mind when you're educating patients with disulfiram that it's not always just drinking alcohol that we think about, right? Whether it's, beer, hard liquor, whatever. You got to remember that there are certain cough syrups, there are mouthwashes, there are, people that cook with wine, for example. So there are other ways to introduce alcohol into the body, and that potential for that reaction still exists, even if you're using small amounts. So again, something to pay attention to, something to educate your patients on with the use of disulfiram. Last medication I'll mention here briefly is topiramate. Brand name is Topamax. This has shown to potentially reduce heavy drinking, also possibly help with cravings a little bit. The most common situation I see this used in practice is if we've got a compelling indication like migraines, for example. Then maybe you'd see topiramate utilized, try to kind of kill two birds with one stone. Adverse effect profile. I've done topiramate in the past on the Real Life Pharmacology podcast. Go into a lot more detail as far as adverse drug reactions and things of that nature. But probably the biggest thing is, if you remember, Topamax equals Dopamax. It makes patients feel really dopey, kind of causes cognitive slowing. I had one patient report to me, just say, "Hey, I feel stupid. Like I can't think. I can't think about things. I'm slow." That's how I had one patient kind of describe that to me. So that's topiramate is a potential option there, but again, probably most common situation is kind of the dueling indications where we're using it for something else, but it could potentially help with their alcohol use disorder as well. All right, well, that's going to wrap up the podcast for today. If you'd do me a huge favor and support the sponsor, meded101.com/store. We've got tons of resources there that can help you pass your board exam and prepare you for your board exam. We've helped thousands of pharmacists, nurses, pharmacy technicians, and we can absolutely help you too. So go check out all those links, all those resources at meded101.com/store. If you enjoyed this episode, do me a huge favor, leave a rating review on iTunes or wherever you're listening. Of course, share us with friends, colleagues, classmates, anybody who could benefit from some pharmacology education. If you got any comments, concerns, questions, don't hesitate to reach out to me at mededucation101@gmail.com. You can also connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. With that, thanks so much for listening. Take care. Hope you have a great rest of your day.